Hi, Andrew Penn, back again to talk about treatment-resistant depression. In this module, we're going to talk about augmentation strategies. Now, augmentation, of course, is the addition of new medications to the existing medications. So when somebody's had a partial response to an antidepressant, but they still have significant depression symptoms, how do we add medications to their existing medications safely to increase their antidepressant response? And we're going to talk about a couple specific agents, particularly lithium and thyroid hormone, atypical antipsychotics. Just as a caveat, there is a module on procedural psychiatry, which would include ECT and TMS, and those are things that you're also going to be thinking about with more refractory cases of depression. So first of all, let's talk about bupropion, because this is probably the most common augmentation strategy for, especially for SSRIs. And now, of course, bupropion, as you know from the antidepressant lecture, is primarily a norepinephrine, but to some extent a dopamine reuptake inhibiting drug. And so it increases the level of both norepinephrine and dopamine at the synapse to improve mood. And we typically do this for people that have had a partial response to SSRIs. The other common use of this drug is if somebody is having an SSRI, they're getting benefit from it, but they're having sexual dysfunction such as inability to orgasm or lack of libido, we may add bupropion as a way of as an antidote to that. And specifically for targeting low energy, because this norepinephrine reuptake inhibition tends to be somewhat energizing. And of course, we also use it for smoking cessation. Now, the downsides to bupropion are is that it is stimulating, and that can result in anxiety for some patients. If it's taken too late in the day, that can also translate into insomnia. And we don't use it, of course, in patients who have had seizures. So somebody has a seizure history, we want to avoid bupropion, because with normal folks, but folks who do not have seizures, it's quite a safe drug to use up to 450 milligrams. Beyond 450 milligrams, the risk of seizures goes up considerably. But for people that are prone to seizures, that risk can be increased with any dose. So we generally just don't go there with bupropion in patients who have seizure disorders. The remission rates in STAR-D were not bad. About a fifth of people got better with monotherapy, and about 30% of people got better when you added this to citalopram. So this is why we see this commonly used in clinical practice. And of course, this is a little confusing because it's a drug that comes in multiple formulations. It comes in an immediate release, which is hardly ever used, a sustained release, in which if you're using that, you want to give no more than 200 milligrams a day. It's typically a BID dosing, once in the morning, once in the early afternoon. But most commonly now we use the once a day extended release, which comes in 150, 300, and 450 milligram doses. So what about Bupropion? So Buspar or Bupropion is a serotonin 1A presynaptic autoreceptor full agonist, which means it sort of activates the receptor, which causes, on the presynaptic side, which causes more serotonin to be released into the synapse. And it's also a postsynaptic partial agonist on the serotonin 1A receptor. And so its indication, its labeled use, is for anxiety, but it was used in STAR-D, and it was very well tolerated. It wasn't terribly effective, but it does have some utility in some people. And there is also some off-label use of this as a reversal agent for sexual dysfunction caused by SSRIs. And it appears in that case to work better in women than it does in men, for whatever reason. And the dose, I often see this drug underdosed. So typical doses are going to range between 50 to 60 milligrams a day. I often would start it at 10 milligrams twice a day and rapidly go up towards that 60 milligram dose, which is easy to do because it's pretty well tolerated. Now, what about serotonin norepinephrine reuptake inhibitors? We have several of these on the market. They vary in their tolerability profiles and their pharmacology. So the two most common ones are duloxetine, which is Cymbalta, which inhibits serotonin and norepinephrine reuptake at all doses, from 20 milligrams up to 120 milligrams. That's a newer medication. I mean, it's been around now for over 10 years. But the first of these medications was venlafaxine, which is Effexor. And this is a drug that has a kind of a curious dosing range at 37.5 milligrams up to 225 milligrams. And it's not uncommon to go off-label into doses of 300 or 375 milligrams of this drug. It does have some difficult withdrawal symptoms if it stops suddenly. And it's also important, so you're going to want to taper it if you do that. And it's also important to know that the drug does not become a norepinephrine reuptake inhibitor until it's dosed over 150 milligrams. Up until that point, it's an SSRI. Desvenlafaxine is the newer version of venlafaxine. It's marketed under the name of Pristiq. It's essentially just the first metabolite of venlafaxine. Levominalcipran is the newest kid on the block. This is the left-handed version of a drug called minalcipran, which you can see there, which is not used, it's not indicated for depression, but it's used in Europe for that reason. In the United States, its labeled use is for fibromyalgia pain. But these medications are all useful for depression and anxiety, and they also have utility in treating neuropathic pain. So you may see patients who are being managed for chronic pain taking these medications as well as for depression. So what about lithium? So lithium is the classic augmentation strategy for antidepressants. Long before we had atypical antipsychotic augmentation, we would use lithium in psychiatry. And lithium's mechanism of action remains somewhat cryptic, but it may cause increased release of serotonin. But the data, regardless of its mechanism of action, the data is pretty strong that it is effective, with a number needed to treat of under 4 in studies. Now, lithium has its downsides. Of course, you still need to do blood draws, even if you're using this in major depression as opposed to bipolar disorder. And that's because you need to keep the dose within a fairly narrow therapeutic window. And of course, there are the side effects that go along with lithium that we'll cover when we talk about bipolar disorder, but the effects on the kidney and the thyroid. Now, what about adding T3 or Cytomel? This was another another option in STAR-D. And so you can do this even if somebody is not frankly hypothyroid. I would not do this in somebody who is borderline hyperthyroid, but if say somebody had a TSH of 2 or 3, I'd still be comfortable using a little bit of Cytomel or T3. Again, the number needed to treat is fairly low, which is always a good sign, around 4. And typically in STAR-D, the doses were between 25 and 50 micrograms per day. And people tend to tolerate this quite well, but you're going to want to give it some time to work. Typically takes about 6 weeks. What about lamotrigine? So lamotrigine you may be more familiar with the treatment of bipolar disorder, and we'll certainly talk about that in that module. So this is an off-label use of the drug, but there is reasonable data to support that adding a lamotrigine to an antidepressant regimen is a reasonable thing to do. The overall number needed to treat being around 9, but for people that had more severe depression or more enduring depression, that is to say depression that had gone on for more than 8 years, their number needed to treat dropped down to 4. And the doses are common, similar to that which we use in bipolar depression, which is usually around 100 to 150 milligrams per day. So I would say that adding lamotrigine is certainly a reasonable augmentation strategy to consider. What about atypical antipsychotics? These have kind of burst onto the scene in the last decade as an augmentation strategy for depression. And there are 4 that have an indication for it that are on label. That would be quetiapine, also called Seroquel, aripiprazole, which is Abilify, olanzapine fluoxetine combination, which is Symbyax, and brexpiprazole, can never say that word, which is known as Rexulti. So any other atypicals are off-label uses. Now the pros to this is they generally work fairly quickly, and they're very useful, especially if somebody has any kind of psychotic symptoms going along with their depression. Now remember, in depression, psychotic symptoms can be more subtle, they can be more vegetative, they can be more thought blocking, they can be more kind of negativism. So definitely for those folks, this is a reasonable augmentation strategy. They're pretty easy to work with. You don't need to do blood level monitoring. Now the downsides is, of course, is they can cause metabolic disturbance and weight gain. They do require you to monitor for metabolic labs such as lipids and blood sugar. And of course, depending on the medication, they can be sedating or they can cause tardive dyskinesia or akathisia. And a lot of people will sort of bristle when you say the word antipsychotic to somebody who has depression, because in many people's mind, this sounds like a much more serious medication. So you do have to kind of navigate your way through that stigma that goes along with this class of drugs. What's the data for them? Well, so the VA did a large study a few years ago called VAST-D, which looked at adding antipsychotics to either bupropion. So you had three choices if you were not remitting on your existing medications. You could either switch to bupropion monotherapy, which 22% of people remitted when they switched off their SSRI and went onto bupropion. You could add bupropion to the existing antidepressant, which is what we talked about in the earlier section, and a slightly higher dose did better on that, about 27%. Or you could add aripiprazole to the existing SSRI antidepressant. So that again is Abilify, and a slightly small percentage, around 29% remitted at that dose. So not earth-shattering differences between these three groups, but a slight advantage to the aripiprazole plus antidepressant group. Now, antidepressants, the bupropion was more commonly associated with anxiety, and the group that got aripiprazole, akathisia was more common, that kind of restlessness that drug can sometimes cause, especially if you dose it too high at the beginning of treatment. Also weight gain, there should be a T in there, and somnolence. Some people do get sedated from aripiprazole. So the bottom line for me is that I'm not a huge fan of atypical antipsychotic augmentation, but I certainly have done it, and I will do it in the future. And when I do it, I try and do it for short periods of time, and I try to reserve them for people that have much more severe depression that is marked by these significant psychomotor changes and major sleep problems, and particularly this kind of ruminative, remorseful, guilty depression, what we once called a melancholic kind of depression, rather than just people who have not done well on the first couple of trials. I would keep this further in my back pocket for those folks. I'm going to talk briefly about S-ketamine and talk more about it extensively in the psychedelic assisted therapy module. But S-ketamine has come onto the market in the last year or so. And this is the left enantiomer. If you go back, remembering your pharmacology, this is the left-handed molecule of ketamine. And it's very expensive. It's running, depending on who's buying it, between $300 and $800 per dose. And again, this is an adjunct to antidepressants. It was not used as monotherapy, and it was never compared to racemic ketamine, which is the generic cheap ketamine. So we really don't know head to head if this confers any advantage over racemic ketamine. Now, certainly some insurance plans will cover it because it has the FDA indication, whereas racemic ketamine was being used off-label, or continues to be used off-label. The other advantage to S-ketamine is that it can be given intranasally, and the joke about this is because most psychiatrists probably couldn't start an IV to save their lives, and so an intranasal approach was much more palatable. And the way it's dosed is that you have to give it twice a week for the first week, and then for the first week, I believe, and then you go to once a week, and then you go every other week. And the person has to stay in clinic and be observed for 2 hours after the insufflation. And we'll talk more about this in a later module. Now, what about stimulants? So stimulants have an interesting and storied history in psychiatry. You can see here at the end of the 19th century, Coca-Cola, which had cocaine in it, would relieve exhaustion, not surprising. That Benzedrine, which is an amphetamine sulfate, was touted as being effective in combating simple depression in the early 1940s. And then a little later in that decade, methamphetamine was a pharmaceutical drug, which was also used for similar purposes. And then after that, Ritalin or methylphenidate was also touted as a relieving agent for depression. Now, what's the data on this? You know, interestingly, there's not a lot. Despite this being a common historical augmentation strategy, there's not a lot of double-blinded controlled trials on this. This is something that has a long history of being used in palliative care in depression when you didn't have weeks to wait for an SSRI to work. Because the person was actively dying. Sometimes stimulants are used to give the person more energy and improve their mood. Um, but really the data on this is pretty thin. Definitely appears that the stimulants, methylphenidate, amphetamine, modafinil, are useful if somebody has marked drowsiness, significant cognitive impairment because of their depression. Now, some people, when those areas of their depression are addressed, their mood follows along and also improves. So I don't want to say that these are not entirely unhelpful, because I have certainly had good luck with them, but these are certainly not first-line augmentations. And just a little footnote about atomoxetine, which is Strattera, which you probably know as an ADHD drug. It has a mild stimulant effect, but interestingly, it was originally formulated to be a bupropion competitor, and it actually failed as an antidepressant. And then I believe it was Eli Lilly tried some studies with it as a ADHD drug and found some benefit there, and so got FDA indication for it in ADHD, but not as an antidepressant. Anytime you're using a stimulant, you want to think about the cardiovascular risks. You want to make sure you're getting vitals. You want to think about getting an EKG, and use these with great caution with somebody if they have a history of cardiovascular disease. So augmentation is a fairly common, it's a fairly straightforward way to boost the effects of antidepressants. Of course, the first thing you want to do is you want to give your original antidepressant a good trial first, because monotherapy is always preferable if we can get away with it. But if you're getting a partial response and you don't want to change the initial medication because you're getting that partial response, bupropion, buspirone, lithium, some atypicals are commonly used for augmentation, and we'll probably see more ketamine and S-ketamine used in the future for augmentation strategies. So in our next talk, we'll cover the options for switching medication in treatment-resistant depression. Thanks for your attention.